All right, good morning. So rheumatoid arthritis affects 3 million people in the United States, and I pulled this off the arthritis.org website. I actually thought it would be even more than that. But 3 times as women are affected. It tends to affect people mostly in their middle ages and all ethnic groups. And worldwide, we're seeing an incidence that's declining. And specifically in terms of our patient population that we see, this disease is now being managed much better medically. So we're going to see a lot fewer, or we have been seeing a lot fewer of these surgical candidates. There's much less disease progression. And so potentially, when we do have to do surgery, we might have other options to treat these people with. We don't really know what the etiology is. It seems to be something associated with this HLA-DR4 on the chromosome 6. So there might be some genetic predisposition. Environmentally, it looks like some type of predisposing vector that can mimic this HLA vector on the chromosome seems to cause rheumatoid arthritis. But classically, you have this deposition of immune complexes in the synovial membrane, which will eventually lead to hyperemia, synovial hyperplasia, first in the joint, and then extends periarticularly, and then to adjacent cartilage bone and then adjacent joints. We see these patients, most of this is done really in either internist office or rheumatology office, but the symptoms are usually pain, swelling, tenderness, deformity. A lot of times this happens gradually, but there are some patients that can present with acute pain secondary to rheumatoid arthritis. You'll see the classic symmetric polyarthropathy of the large and small joints. Vasculitis can also be an issue, and so most of these patients, if I am considering surgical intervention, especially in the forefoot, I usually do get a vascular consultation because you get basically an attacking of the endothelial cells, and so this can also lead to atherosclerosis. And so a lot of these patients are at higher risk for cardiovascular events, especially after foot and ankle surgery. Neuropathy is also prevalent, but this tends to be more subclinical. We'll get our standard radiographs, and again, you can see some of the classic periarticular erosions and osteopenia. I think MRI is really the gold standard, especially when you're looking to catch this early on and see early changes. It allows us to treat it more aggressively early on, especially medically. Again, most of these things will be done by our rheumatology colleagues, but you can get the blood tests. Rheumatoid factor, really 85% of the time will be positive, and if you have patients with elevated ESR, rheumatoid factors, age of onset is much more predictive of more rapid progressive radiographic disease. I also order the anti-CCP test, which is a more specific marker for rheumatoid arthritis than RF, and it's also more prognostic for more severe joint damage. Physical examination, early on it's going to be more pain, and later on as the disease progresses, and I discussed about the soft tissue changes, you'll see more of the deformity. But 94% of patients with rheumatoid arthritis will have foot and ankle symptoms. So I think most people think classically of the deformities in the fingers and hands, but 94% will be involving the foot. The risk is certainly higher with the duration of disease as the disease progresses to the lesser joints. But there's also a marked reduction then in mobility and functional capacity of these patients. And so what you see on examination, you see this classic chronic synovitis, so swelling of the joints. You'll get the destruction of the periarticular soft tissues, gives you instability at your metatarsophalangeal joint. You eventually get the hallux valgus, which is very common in these rheumatoid patients. Eventually then that starts pushing over laterally, so you get a dorsal displacement, dislocation of the lesser toes. Then you get the plantar displacement, metatarsal head, so you get the fixed lesser toe deformities and a lot of pain, specifically plantarly, but also dorsally. You get a lot of callosities, rheumatoid nodules. You get stress fractures throughout, specifically the metatarsals, primarily from the gross osteopenia as well as the malalignment. But this is also very common as the patients get with the NTP and the first rate instability. You get a lot of hindfoot valgus deformity, so you'll see a lot of fibular stress fractures in rheumatoid patients as well. And it's not the focus of this talk, but certainly hindfoot disease is prevalent in this population. So we try and modify the shoe wear. The goal here is really just to slow the progression of the disease and certainly try and prevent any type of ulcerations. And the medications is really, the treatment has really been revolutionized in the last 10 years. So there's no cure. We try and decrease the symptoms and decrease the inflammation, slow disease progression, and there's no one drug that's good for everyone. So again, as we always do with all of our patients, the rheumatologists really have to treat every patient individually. So as you see and evaluate patients for potential surgery, you really have to have a good communication with the patient's rheumatologist. So in general, anti-inflammatories, non-steroids are good early on to help with the pain. It doesn't really do anything for disease progression, but can help limit some of the inflammation, so it can give some good pain control. Some of our colleagues will prefer oral corticosteroids more than we would necessarily prescribe it. That can be helpful initially. Once you start getting on the regular rheumatoid medications, you'll stop that. And corticosteroid injection, I think, can help a lot too. Again, help to decrease some of the inflammation, some of the synovitis, can help improve patients' pain and range of motion and gait. And then this is very busy slides, but I just wanted to give a general overview of some of the medications. The traditional disease-modifying anti-rheumatic drugs are really, you're trying to inhibit this TNF and IL-1 because this is what stimulates the inflammation in the joints. And it's these enzymes that erode the cartilage, it erodes the periarticular bone, then you activate the local osteoclast, which leads to more bone resorption. Eventually you get this hyperemia in the joint. That also increases the local osteopenia, and so you get more progressive joint and soft tissue destruction. Some of the newer medications are these disease-modifying drugs. So there's Plaquenil and sulfasalazine. These are really the first-line agents. Plaquenil, of course, an anti-malarial medication, but in general, pretty good side effect profiles. When you have more of an aggressive seropositive disease, methotrexate is still usually the first-line defense. Some of the other medications are listed there. Some of the newer medications that we know more, the Enbrel, Humira, and Remicade, this is used in more patients with more aggressive disease who have failed the primary medications, and these are effective when used in combination. And some of the newer therapies are so-called biologics are being used now, so if patients have failed the other traditional DMARDs, then you can move on to something like this to try and break up that immunogenic cascade. So when we're finally considering patients for potential surgery, you have to evaluate the patient, and sometimes the deformities are pretty significant. So you want to obviously look at the skin. A lot of these rheumatoid patients have this friable skin, so it's very important to plan out your incisions appropriately. Neurovascular status, as we discussed before about the vasculitis, but again, you want to make sure they have adequate pedal pulses, and I frequently send these patients to vascular consultation just to be sure. And the goal when we're thinking about the surgery is really to correct the malalignment, to reestablish a plantar weight-bearing surface, and to try and alleviate their arthritis. When you're looking at the lesser toe deformities, again, the inflammation leads to disruption of all the ligaments in the capsule, so you have tremendous deformities and malalignment, dislocations. You have an imbalance of your intrinsics and your extrinsics, and then you also get subsequent callosities dorsally on the PIPs and plantally at the metatarsal heads. And so you get toes that look like this. Again, your metatarsal head is plantar flex, which increase piece pressures. The plantar fat pad is pulled out distally, and you get a lot of callousing and ulcerations. And so again, we're trying to restore the plantar foot for shoe wear and trying to alleviate the pain and deformity. Classically, these are the two procedures that we know. Hoffman, back in 1911, described resecting the lesser metatarsal heads to help to correct the deformity, provide pain relief. It's been a very successful procedure throughout the years. Clayton had recommended combining resection of the metatarsal heads with the resection of the proximal phalangeal base, and this is really now more out of favor. In general, for the PIP joints, you might have to do a rigid correction, or sometimes you can get away with a closed osteoclasis. And the problem here is, again, the hallux valgus is increased because you get the severe clawing, and they work together, as we talked about the synovitis before, which can loosen the structures, but also as you get increased in deformity laterally, you have less support. And that leads to increased valgus, which leads to increased transverse metatarsalgia. And the reality is that what you have to try and restore is that stability of the first raise, stability of the medial column. So a lot of procedures that have been described in the past, the problem is you do not have the first raise stability. And so in the end, for all these procedures for the rheumatoid forefoot, it's really the first raise stability that's the most important thing, much more so than how you resect the lesser metatarsals to correct those. And so the problems here, again, the soft tissue correction is not maintained, so you'll get recurrency of deformity and you get worsening of the lesser toe alignment. Arthroplasty and silicone implants in the past have shown decent results. Really don't have any studies on metallic implants, but the bottom line is over time these can lead to implant fracture. You can get a significant synovitis and osteolysis, and that can complicate our salvage options and might require a revision procedure with a likely interpositional bone graft arthrodesis. And so again, historically, the forefoot procedures have failed when you do not have adequate first raise stabilization. And so that's why the gold standard is still the first metatarsal phalangeal joint fusion. For the lesser toes, again, the resection is really not as important as the first ray. But classically, the treatment has been the resection arthroplasty. There is some new literature that I'll talk about in terms of trying to have more joint-sparing procedures for the lesser toes. And again, this can be possible in certain patients, as I mentioned, but it's the first ray stabilization that's the most important. So Krause published this a couple years ago, And in general, you can look at the lesser toes individually. And so if you have joints that really have minimal wear and tear of the cartilage, so it's typically less than 1/3, and if it's one or two toes that have this minimal wear, you can potentially do a joint-sparing arthrolysis procedure. So if you have 3 toes affected, then you're not going to do this procedure. If you have only 1 toe, like the 5th toe that's not affected, you would still do a resection there. But in general, when you try and do this procedure, you can do an extensor lengthening, you can release the capsule, the adhesions, and the results they have are pretty good and potentially offer more metatarsophalangeal joint stability in the long run. And when you combine this with fusion, again, the stability of the first ray realignment is really the key to success and the long-term results for this procedure. So the gold standard, this was described by Coughlin in his landmark study in 2000, is really the first metatarsophalangeal joint fusion, lesser metatarsal head resections 2 through 5, and fixed hammer toe repairs. And he showed excellent results, 96% excellent to good results. There were no non-unions. Pain was resolved in 91% of patients, really minimal recurrence and minimal redislocation. So to perform this procedure, basically I approached the first metatarsophalangeal joint dorsally. You could also approach it medially, and then there are 2 longitudinal incisions in the 2nd and the 4th interspaces. I prepare the first metatarsophalangeal joint first, and then I end up fixing it last. So first you want to remove all the proliferative synovial tissue. I prepare this now using cup and cone reamers, but you want to put the hallux valgus really at 10 to 15 degrees of valgus, 20 to 25 degrees dorsiflexion relative to the shaft. You want to make sure that toe is neutrally rotated. Then I pin it and I hold it there reduced, and then I go to the lesser toes. So I approach these through 2 dorsal incisions. I do my PIP resection arthroplasties if I need to, otherwise you can still consider doing a closed osteoclasis. I do a synovectomy at the MTP joint, and then you try and do your resection. So again, you want to try and maintain a parabola. So in general, the first and second toes should be about the same length, and you come down from there. You want to try and resect as little as possible, but you have to have a tension-free reduction of the joint. You do preserve the phalangeal base, so we don't take that off anymore as the classic Clayton procedure describes. You can try and leave the extensors in place dorsally, and the amount resected just depends on the overlap and the tension that you have at that metatarsophalangeal joint. So in general, you should remove usually about 1 centimeter, but you want to maintain the parabola, but you have to make sure it's a complete reduction. There's no tension on that reduction. I bevel it slightly dorsal, distal, proximal plantar to try and reduce the risk of plantar prominence. Sometimes people describe suturing the extensor tendon into the joint to try and prevent that as well. And then once that's done, I pin it, and then I go back and I finish the fusion. You can fix it with 2 crossing screws. You can fix a plate and screws. And again, as Dr. Weil was mentioning, I close this with the tourniquet down to make sure that there's no issues with perfusion distally. Sometimes if you've done too much of correction, the toe is to extend plantar flex, you can extend it. That can sometimes bring back the perfusion. Sometimes, if necessary, you remove the pin. People discussed yesterday also potential nitro paste if you have severe issues in getting the perfusion to return. Post-operatively, I put them in a cast initially for 2 weeks. I usually give them a heel-down weight-bearing shoe so it prevents them from putting any weight on the front of the foot. At 6 weeks, I remove the K-wires, and then I do also the Coban to help with the swelling at that point and maintain the correction. And I keep them in a hard shoe or a boot for 6 weeks. They're back in regular shoes at 3 months. These patients have a lot of risk factors, though, so they're definitely prevalent for complications, non-unions, malunions. The foot length can be off. They can have issues with balance because this is a large correction for them. They can have persistent metatarsalgia. They can still get callousing. So it is a complicated procedure. It's a large correction. We all know about the risks of infection and wound healing. Part of this can be from this low-level vasculitis. So that's, again, in these patients where I always get a vascular consultation. The skin issues that I talked about can be very friable. So be very careful with the soft tissues during your procedure. And again, the use of the medication. So I think it's always been a question, do you stop the medication? How long do you stop it, before or after? And so the literature is a little bit confusing with this. Grannon looked at it and he felt that there were fewer infections when you continued to the drugs. Bibbo felt that you have a very high infection rate and wound healing, 32% in these patients, but there's no difference whether you use the medications in the peri-op period. And then Den Broder felt that it was more common to have wound adhesion issues when you're on medication. So classically, I still stop the medications 1 week before and 2 weeks after. The reality is that the most recent study shows that the infection risk in this group is much higher than the non-rheumatoids. especially if you've taken your medications and some of these newer medications within one interval prior to the surgery. So 7 times higher risk, and the risk is highest in foot cases. So you have to balance the risk of stopping the medications versus infection. So again, this is where it's good to have a good relationship with your rheumatologist. You have to understand what type of rheumatoid disease they have, what's the extent of the disease, how well their disease is being controlled, what is a possible risk for these patients of a disease flare-up if they stop the medications, and what are the possible consequences of this flare-up even beyond the foot, extra-articular and also vital organs. And so you have to balance, again, you have to treat every patient individually. My preference in general, stop 1 week before and 2 weeks after. So in summary, the pain from rheumatoid arthritis is really caused by this hypertrophic synovitis in the joint, which leads to arthritic destruction, deformity, intra-articularly and then extra-articularly. It's a chronic disease that we do not have a cure for. It leads to ongoing joint destruction, recurrent deformities, even with skilled surgery. The medications have really revolutionized the way this treatment, the treatment has come along, so that now we can slow the disease progression, and we are seeing fewer of these patients present with the classic deformities. But surgery is very successful. It offers a high rate of pain relief, patient satisfaction, functional improvement. The current evidence, the gold standard is still, for first MTP arthrodesis, you have to have a rigid stabilization of your medial column, lesser metatarsal head resection, but some of these joint-sparing forefoot procedures, especially in the lesser toes, may ultimately offer us an effective surgical alternative in combination with the newer medications. Thank you.